Hello and welcome to Sleep Review's webinar, How to Improve Adherence in Patients Titrated at Home by Auto CPAP. I'm Sri Roy, editor of Sleep Review, and I'm here with three esteemed speakers, Drs. Dennis Ockley, Amy J. Aronsky, and Carl Stepnowski. After the three presentations, we'll answer as many questions as we can live. Submit your auto CPAP-related questions via the Q&A box on your screen. Also, the slide deck is available for PDF download via the slide download and links box on the right side of your screen. The webinar is sponsored by Fisher & Paykel. For the AAST credit, the CEC is available for the live webinar only, which applies to you if you're watching Wednesday, May 30th at about 11 a.m. Pacific time. Today's webinar is being recorded, but the pre-recorded version isn't eligible. On the registration page, you must also have said yes when asked about wanting the credit, which was the default. For privacy reasons, we won't be submitting the full roster to the AAST, only those attendees who requested the credit. So you must watch all three presentations and complete the exit survey on the left side of your screen. Even if you don't want the credit, we'd appreciate it if you take the survey. Once you take the survey, the form will simply close. If you don't get the certificate needed for the AAST credit by July 1st, email me at sroy@medcore.com. Let's start today's webinar with two audience polls. Please select from the choices on your screen, then click the Submit button so we include your response in the calculations. On average, how many patients do you normally titrate in lab for CPAP in any given month? 0 to 20, 21 to 40, 41 to 60, 61 or more. Remember to click the Submit button so your response is included. Let's take a look at the results. Most of our audience today says 0 to 20 patients are titrated in lab in any given month. That's roughly 40%. The second largest, say 21 to 40 patients in lab. The next, it's about tied with 41 to 60 in lab each month, and 61 or more is a small portion of the audience at about 5%. We now have a related question. It's our final audience poll today. On average, how many patients do you normally send home with an auto CPAP without lab titration in any given month? So these are the same options as in the previous poll, ranging from 0 to 20 to 61 or more. So go ahead and pick your option, and then we'll take a look at the results and click the Submit button. So now we're going to look at how many patients you normally send home with auto CPAP without a lab titration. And that 0 to 20, 80% of you approximately do about that many auto CPAPs in any given month. And then the next largest is 21 to 40. And then a few folks do more than 41 patients who they send home with an auto CPAP each month. So that gives us a good feel for today's audience, and we think today's webinar will give you real-world advice for both in-lab and at-home scenarios. It's now my pleasure to introduce Dennis Ockley, MD. Dr. Ockley is Director of the Center for Sleep Medicine at Metro Health Medical Center in Cleveland, Ohio, and Professor of Medicine at Case Western Reserve University. He is board certified in sleep medicine, pulmonary disease, and critical care medicine. Dr. Ockley directs the Center for Sleep Medicine at Metro Health Medical Center and performs research on sleep with a focus on sleep-disordered breathing in inpatients. He has authored and co-authored more than 100 original scientific manuscripts, chapters, reviews, and abstracts. He is a member of the American Board of Internal Medicine Sleep Medicine Test Writing Committee and has served on national committees for a number of pulmonary and sleep medical societies. Welcome, Dr. Ockley. We're ready to hear your insights.
Great. Well, thank you, Sri. I'd like to thank Sri and Sleep Reviews for inviting me to participate in this webinar and this esteemed panel. It's really a great topic, and I think we'll all learn something from each other about this. So I was asked to speak about in-lab versus at-home auto PAP titrations and how this might impact adherence. So what do we know about this in terms of evidence? I do have just a few financial disclosures to make, none of which really are relevant to the topic, but I am required to tell you, as Sri mentioned, that I am on the ABIM Sleep Medicine Exam Committee, and that there will be no exam questions disclosed during the presentation. Please don't send me any angry emails. So the objectives in the next 18 to 20 minutes, what I wanted to cover is just basically to review a little bit about auto CPAP, and this goes by various terms: auto PAP, APAP, auto-adjusting CPAP. I'm going to refer to it as auto CPAP. What we know about recommendations currently in terms of indications, contraindications, and then discuss some of the data comparing auto CPAP to CPAP at a fixed pressure and how this might impact outcomes beyond just adherence, and then also describe what we know about what's been more recent studies looking at using a total out-of-lab pathway with home studies followed by auto-PAP compared to doing everything in the lab, and how this may actually influence adherence to PAP therapy. So I'm sure most of you are aware auto CPAP devices, they are self-adjusting devices that work to adjust the pressure within a set limit that we predetermine. And they respond, by and large, to respiratory events. So they're looking for snoring, apneas, hypopneas, and they should not be adjusting to artifacts. So the primary issue here being leaks, where you don't want the device up or down titrating based upon false information. So the original auto CPAP devices all used snore detection, but the modern ones really use a combination of both snore detection and flow detection to make adjustments. And the algorithms are preset within each device, and I'll show you a little bit about that in terms of how they might be different and respond differently. And then the modern devices, so originally when auto CPAPs came out, they couldn't really reliably distinguish between obstructive and central apneas, but now using either cardiac pulsation detection on the flow tracing or forced oscillation techniques, do a fairly reliable job of differentiating between obstructive and central apneas, and that becomes important when they are self-adjusting. We'll talk about that some more in a minute. And all the devices, after some sort of stable breathing pattern, will generally start to down titrate the pressure, which can lead to changes in how the overall mean pressure is over the course of the night. So in 2008, the American Academy of Sleep Medicine came out with practice guidelines for auto CPAP devices. So at that point in time, they had recommended what were indications for use of auto CPAP included primarily patients with moderate to severe obstructive sleep apnea, and they also gave a number of relative contraindications. So patients with congestive heart failure, particularly low ejection fraction, and particularly those at risk for periodic breathing where they have central sleep apnea. But they also included other conditions in which central sleep apnea may be present. It includes opioids, neuromuscular disease, things like that, in part because a lot of the devices cannot distinguish between central and obstructive apneas. COPD is listed as a relative contraindication in this paper, as well as other conditions that can cause hypoventilation, including neuromuscular disease, opioids in there as well. And this is in large part because auto PAP devices do not detect hypoventilation and would not respond if that were ongoing and can potentially worsen the situation during the course of the night. And then if there's significant hypoxemia that's present independent of the sleep apnea, the devices will not respond to that. They won't recognize that. And so if you had somebody, for instance, that had underlying cardiopulmonary disease that predisposed them being significantly hypoxic, or even in cases of obesity hypoventilation, particularly morbidly obese patients, these devices were not recommended. So as I noted down there at the bottom, this is from 2008. If you go to the ASM website, they are in the process of updating these guidelines. They are in final stages. I've been told by a member of the committee they can't release any results yet, but apparently they're not going to have any dramatic changes in these past recommendations, so we expect that it'll be pretty similar. So as I mentioned, the auto PAP devices all have proprietary algorithms in terms of how they respond, and they actually respond a bit differently. So this is a nice study that was actually a repeat of a study done almost a decade ago, where it's a bench study in which they created a simulation of both obstructive apneas and obstructive hypopneas. And so if you look in the first column here, those black hash marks are representing obstructive apneas, which are simulated. And in the second column, the dark gray bars represent obstructive hypopneas. And so then going across the rows, the first row is REF, that's a reference device. And so what you're seeing there is this is about a 30-minute window here for the obstructive apnea group, is having apnea, apnea, apnea. But the device is set at fixed pressure of 4 centimeters water, so it does not respond. And then in the second column, you see the hypopnea is repeated, and again, fixed pressure does not respond. So you can see going through these different devices labeled D1 through D5, there's a variety of how these devices actually or variation in how these devices actually may respond. So for example, D1, in the first device there, you can see the simulated apnea is going on, and the device did ramp up the pressure to about 8 centimeters of water, and it stopped increasing. Likewise, for the hypopneas, it started ramping up. It caused somewhat a reduction in the hypopneas, but did not fully eliminate them. So this device would be a bit concerning to use in clinical practice because it doesn't appear to respond all that adequately. You compare this down, we'll jump down to device D3. So you see here the apneas are going on initially, and the device starts to ramp up the pressure, getting up probably to around 14 centimeters of water, and all the apneas are obliterated. However, the pressure is held at that setting for the duration of the trial. Likewise, when you look at the hypopnea column, it does a similar thing in terms of increasing the pressure and ramping up. When the hypopneas are eliminated, it even continued to ramp up and did not stop going up or down titrate. There's a second, we actually did 11 devices in this study, so the second graph. And just to highlight a couple of these and show you how differently they may behave compared to the ones we just discussed. If you look at the row D8, you'll see here the device ramps up for the obstructive apneas, eliminates the apneas, and then it starts to down titrate the pressure until they reappear, and then it goes back up again, and it down titrates. And then with the hypopneas, there's a similar sort of pattern. And this is actually something that would probably be more ideal in terms of ensuring control of the sleep apnea while at the same time reducing the CPAP pressure required to do that. So the devices behave a bit differently. So when we set patients up with auto-adjusting devices, obviously it's important to select an appropriate interface. In contradistinction to usually doing an in-lab titration where the technician is working with the patient over the course of the night and may change the interface, this is a sort of, you're going to be doing this while the patient is awake, not during sleep. And you're going to try, hopefully, find something that will fit them well and not lead to leaking, particularly over the pressure settings that may be determined. So it's a little bit different from choosing an interface based off of a sleep study because you don't really have a period of trial. Then we determine the pressure limits, and this is often done empirically. The ranges may be anywhere from a lower limit of 4 up to a lower limit of 10 to a higher limit of 10 to 12 up to 20. So you may see settings ranging like 4 to 12, 4 to 10, or conversely 10 to 20. And oftentimes we make these assessments or judgments based upon how severe the patient's known sleep apnea is, as well as other issues such as obesity, and particularly patients who are morbidly obese may require higher pressure ranges. You do need to know that your device, so whatever either your institution or your DME supplier is supplying, it's important to know kind of how it will function. And then, obviously, once patients are started on auto-adjusting devices, we want to follow them very closely. So we want to adjust the interfaces needed to make sure we're eliminating problems with leak, adjust the pressures as needed if their downloads are not looking optimal, and then they need close clinical follow-up and a lot of help from DME companies with doing this. So this is just in contradistinction to auto-adjusting. This was from the American Academy of Sleep Medicine practice guidelines as well about manual titration of PAP. And what you see here down in the lower left corner is starting off at a low pressure, and then as the technician sees the patients having apneas, hypopneas, respiratory event-related arousals, they will gradually increase the pressure, trying to eliminate all those events. Once those events are eliminated and breathing has been stable for a predefined period, usually 30 minutes, then down titration may occur. So this is all occurring manually based upon inspection of the flow tracing in real time. When we set patients up on fixed pressure CPAP, it's very similar to auto PAP, although usually we're picking the interface off of the sleep study, and so this is maybe a bit more reliable and not require a change. We're going to select a fixed pressure. It's going to be the best pressure determined by the sleep study. And then again, you want to monitor the downloads closely, looking for problems with leaking, determining if the pressure was indeed adequate once they're out of the sleep lab, which actually raises the question, if it's not adequate and they're not leaking and there's not another problem going on, how should the adjustment be done? Should you empirically go up by 1 to 2 centimeters of water? I have some colleagues that do that. Conversely, you can consider placing patients on an auto CPAP device for a short period and reassess the pressure, or bring them back into the lab to retitrate them, which obviously is going to be labor and resource intensive. And then again, close follow-up is warranted. So we talk about the body of literature comparing auto-adjusting devices to fixed pressure devices. There's really sort of two approaches that have been looked at. The first is comparing auto CPAP to fixed CPAP for the treatment of sleep apnea based on patients having had a sleep study. Usually they were titrated, but then the patients are randomized to one of two models. One is a parallel study design where some patients are randomized to auto CPAP and they're kept on that for the duration of the study versus being randomized to the fixed pressure CPAP determined from the sleep study. And then there's also a crossover design in which patients are randomized to either start with fixed pressure or auto CPAP, and then after a predefined period, usually like a month or 6 weeks, they switch over to the opposite treatment. So in the crossover design, they serve as their own controls. So this is one body of literature, and we'll review that briefly. And then, as I mentioned at the beginning of the talk, there's also been a number of studies looking at doing a home route where patients undergo a home sleep study and then auto PAP versus doing a PSG in lab and a titration in lab. Interestingly, in the home routes, though, the auto PAP use has been generally limited in that the patients will be on auto PAP only for 3 to 7 nights before they determine a fixed pressure off of that. So we'll come back to that here in a few minutes. So there have been a couple of large data analysis looking at the use of auto CPAP versus fixed pressure. And this is the first body of literature, which is comparing patients sort of coming out of a sleep study and then placing them on therapy. This was a fairly large one from the Cochrane database systematic review group, and they looked at 30 studies in which patients were placed on auto CPAP or fixed pressure CPAP. So they were all randomized controlled trials. They all were adults, and they all had obstructive sleep apnea. They had to be on therapy for a minimum of 2 weeks. And what they found was that there was only a difference of 0.21 hours in average adherence per night with the use of auto CPAP. So it did favor auto CPAP, but to break this down, I did the math. This is about 12 to 13 minutes per night more use with the auto CPAP. This was statistically significant, but the clinical relevance obviously is a little questionable. Interestingly, this is only seen in the crossover studies in which the patients were their own controls, but when they looked at the studies that only use a parallelized model or a parallel model, there was no difference in the adherence. So this was followed up by a meta-analysis in 2012, which used a similar sort of design in terms of looking at only adult patients with obstructive sleep apnea, and they looked at patients or studies where their patients were randomized either auto CPAP or fixed pressure and had a minimum duration of use of at least 2 weeks, although the longest study was 12 weeks. Based primarily on how they defined entry into the study, the Cochrane database review could allow oximetry to qualify patients. In some of their studies, this required all sleep studies to be done, so it was a smaller number, 19 studies, about 900 patients. And before we get to the adherence data, they did actually report on a number of other parameters. So one was the post-treatment Epworth Sleepiness Scale change. So for those who are not familiar with this, this is a forest plot, so the studies are listed in each row here. And on the far right, you see this line, and each green dot here represents the mean from a single study. So on one side, it favors auto PAP. On the other side, it favors fixed pressure CPAP. The bars associated with the green dots are the confidence intervals. So if those overlap the line, those studies are not statistically significant. And then they pool all the data together and see what they find. And what you see for post-treatment Epworth Sleepiness Scale down here in the red box, they found favored auto CPAP by 0.2 points on the Epworth, so not a big difference. And that black diamond there overlaps that line, so it was not statistically significant. So the trend towards favoring auto CPAP, but not significant. This is looking at post-treatment AHI, so how well do the devices do in terms of controlling sleep apnea. And you can see that the AHI with the auto CPAP devices was slightly lower, but again, the diamond box down in this red rectangle crosses the line and is not statistically significant. And we look at, interestingly, a few studies looked at patient preference, and this is an odds ratio that's being reported here. And so when they pooled the data from these 4 studies, they found that patients generally preferred auto CPAP over the fixed pressure CPAP, and the odds ratio is 3.6, and that is statistically significant. The diamond does not overlap the line. And then when you look at mean pressure, so how much pressure is needed over the course of the night, as you might expect, if the auto CPAP device is working appropriately, the mean pressure was less on average by about 1.6 centimeters of water with the auto CPAP, which might reflect why patients prefer this. And this, again, was statistically significant. However, the big outcome we're concerned with or interested in is adherence. And so just like the Cochrane database review, they did find that auto CPAP did lead to better adherence. But here it's only 0.23 of an hour. So again, that's only about 14 minutes more use per night. So statistically significant, The diamond does not overlap the line, but clinically, a little questionable. So when we compare these types of studies, there's a large number of studies now that suggest that auto CPAP and fixed pressure CPAP are actually equivalent to each other in terms of controlling the sleep apnea, controlling the symptoms related to sleep apnea, particularly sleepiness, and then quality of life. And auto PAP appears to be slightly better than fixed pressure CPAP in terms of adherence, but the studies are limited to a max of 3-month duration, so we don't know about longer term by and large. And then the clinical relevance of this statistically significant improvement of 12 to 15 minutes is a bit questionable. There is one study. It's not a randomized controlled trial. It's not even controlled, but it did look at auto CPAP use over long-term adherence. It was a prospective observational study, about 90 patients who were placed on auto CPAP after their initial diagnosis, and they were followed for a mean of 5 years, so a pretty long time. 75% of the patients did continue to use the therapy, and those who remained on it, 94% of that 75% would meet criteria for adherence based on what we use as standard definition. And most of these patients, you could determine after 2 weeks and 6 months of therapy who is going to remain compliant with therapy. So this isn't controlled, but if you compare this about what we know with fixed pressure, it looks maybe a little bit better, but obviously we need controlled data to verify that. So the other body of literature was using this whole home arm versus the in-lab arm. So I put together the main studies that really have looked at this. So you can see each study's in a row, the year they were done, the number of subjects. I call your attention to the auto PAP duration here, and it's very interesting that all these studies only looked at a short-term use of the auto CPAP. 2 to 3 nights up to 1 week was the most. And then the downloads were inspected and patients were placed on fixed pressure CPAP. So 4 of the studies showed that anywhere from 4 weeks to 3 months, there was no difference in adherence, regardless of the pathway. But 2 studies did show that auto CPAP was better by 0.6 and even 1 hour per night, which both statistically significant and both probably highly clinically relevant. Again, but this is just with short-term auto CPAP use. So a couple of caveats. Almost all these studies had considerable exclusion criteria. So as ASM recommended, patients with significant cardiopulmonary disease were by and large excluded. Patients at risk for central apnea hypoventilation were always excluded from these studies. The studies that were doing the home versus all in-lab compared fixed pressure to auto CPAP, but the auto CPAP was only utilized, again, for a week at the most. The studies were limited, again, to 3 months. Most outcomes were generally equivalent, so auto CPAP certainly is not inferior. And then all these studies were conducted in a research trial mode, so you have to consider that because significant support comes along with that in terms of study coordinators frequently contacting the patients, suggesting things as needed, which may not be reflective of real-world practice. So to summarize, auto CPAP and fixed pressure, they appear to be equivalent regardless of how you kind of slice or dice the data. Certainly they're equivalent in terms of control of sleep apnea, control of patient sleepiness, and quality of life. But auto CPAP is at least equivalent and maybe slightly better than fixed pressure CPAP in terms of adherence. And there's data suggesting when you use this for continuous treatment, and then also when you use to titrate patients with the goal of putting them on a fixed pressure device. So I think with that, I'll finish and pass on to Dr. Aronofsky. Thank you.
Thank you so much, Dr. Ockley, for that insightful and comprehensive literature review. Now I am happy to introduce Amy J. Aronsky, DO, FAASM, who is board certified in pulmonary critical care, sleep medicine, and behavioral sleep medicine. She is Senior Medical Director for CareCentrics, where she oversees utilization management and clinical policy development. She was previously Medical Director for Quality for the state of Pennsylvania, and she has worked with CMS to develop alternate payment models. She previously served as a director for the American Academy of Sleep Medicine. Welcome, Dr. Aronsky. We're ready to hear your experience.
Thank you, Sri. Appreciate the opportunity to talk to everybody about the payer perspective in using auto PAP. I was interested to see the results of the little survey that we just took that showed that everybody is familiar with auto PAP, and in fact there seems to be a significant shift in using auto PAP as a primary method of treating our patients who are diagnosed with obstructive sleep apnea. So today we're going to review some of the clinical indications and the clinical guidelines that we use from a commercial payer perspective in order to prescribe the APAP device. And then we're going to talk about the follow-up that these patients should undergo and when it would be appropriate to bring them back in lab for a PAP retitration if they're actually failing the APAP device. So I always like to give a little bit of a joke to sort of break it up a little bit. You know, the joke basically says that even though the insurance company wants us to do one thing, the doctor wants us to do another thing. What we do as a commercial payer is that we apply best clinical practices to make sure that the patients get the primary care that they need to have. So our goal is actually to diagnose patients with sleep apnea and provide the most effective treatment for them. We're on the side of the patient. I know sometimes people don't believe that, but that actually is true. So the first question that we ask is an in-lab PAP titration, CPT code 95811, medically necessary? And when we consider whether or not a requested procedure or an item is medically necessary, we look at the health plan's clinical guidelines. The clinical guidelines can vary from health plan to health plan, but generally they're evidence-based. They include best practices. And it's important to remember that the guidelines are simply guidelines, meaning that there can be variation in the guidelines. And we can approve things outside of the guidelines if it's in the best interest of the patient and there is an extenuating circumstance. So just as a general comment, and again, keeping in mind that Aetna's clinical policy could be different than United Health's clinical policy, but as a general guideline, patients with severe drops in oxygen saturation on a diagnostic sleep study are going to qualify for an in-lab PAP titration. And patients who have significant comorbid conditions, and Dr. Oakley highlighted some of those, so significant congestive heart failure, COPD, pulmonary hypertension, some cardiac arrhythmias, neuromuscular disease resulting in CO2 retention, evidence of obesity, hypoventilation syndrome. These types of conditions will warrant in-lab PAP titration. So again, you know, check the clinical guidelines, be familiar with them, but these conditions will generally qualify the patient for in-lab testing. Other conditions that will qualify the patient for an in-lab PAP titration would be a significant secondary comorbid sleep disorder, and that could include evaluating the patient for narcolepsy, a possible injurious parasomnia like REM behavior disorder, significant central sleep apnea based on the ASM clinical guidelines, chronic opiate use, and then the failure to resolve symptoms on an APAP device. And we're going to talk a little bit more about that. It's very important when requesting any type of sleep study, be it a home sleep study or an in-lab titration study, that prior authorization be obtained. You can do a procedure and then request a retrospective authorization. It's quite a bit more difficult to get approval for such a request. So it's better to request it prior to the procedure being performed. And when you're making the request, be sure to submit all the necessary clinical documentation. So if you're requesting an APAP device, you'll want to include your diagnostic sleep study, evidence of failed APAP attempts. So that may include the compliance downloads that shows that the patient has actually been using the APAP device, pulmonary function studies, echocardiogram results that show to reduce ejection fraction or elevated pulmonary artery pressure, any type of pertinent labs such as an arterial blood gas or hematocrit, and any evidence from recent supporting clinical notes. That's really going to make this process quite a bit easier if you submit all the information up front. The initial clinical review team is going to be able to have everything at their fingertips. They're going to compare the information that was submitted to the clinical guidelines, and if it meets the clinical guidelines, then the first review team is going to be able to approve your request. If your request is not able to be approved because it does not meet medical necessity guidelines, then you're going to receive a denial, or what we call an adverse determination. If you receive an adverse determination, there's a couple of different things that you can do. If you have additional information that you think would change an adverse determination to an approval, the physician or the nurse practitioner or the physician's assistant could request a peer-to-peer call. The peer-to-peer call would be conducted typically by the physician who conducted the initial review of the case, and it would be used to provide additional information to the physician who performed the initial review. If, with the additional information, the patient is able to be qualified for approval for the requested PAP titration, then the adverse determination would be overturned and would subsequently be approved. It's important to remember that when the peer-to-peer call is conducted, it may not be done by a sleep physician, so you could even get a cardiologist or a dermatologist, so they may not know as much sleep medicine as you might have hoped, but they will be making the request. They will be performing the peer-to-peer request nonetheless. The other option is to perform a health plan appeal, and you can do that after. You can skip over the peer-to-peer call. The qualified healthcare professional or the member could request a health plan appeal, and this is typically done when a request is being made outside of the clinical guidelines. And there are 3 levels of appeal. So if the adverse determination is upheld, it can continue on for 3 different steps until all steps have been exhausted and the adverse determination holds. So the peer-to-peer call, again, done by the qualified healthcare professional. The health plan appeal can be done by the member, by the patient, or by the qualified health plan, by the qualified healthcare professional. If the patient qualifies for an AutoPAP trial at home, the suggestion is that you request the AutoPAP through the health plan preferred DME provider. And a lot of times we'll have physicians who want to request the AutoPAP device from a provider that they feel comfortable with and they know provides local service, and that's great. But we want to make sure that that this provider also is within the network for the member. That will give the patient the preferred pricing at the in-network rate. So that is something that should be considered. Then the patient will be set up with the equipment. The setup could occur in the DME provider facility or home. It could occur in the sleep center or even in the physician's office. And typically within that time, the patient is shown how to use the equipment and is fit for a mask, etc. So remember that they're not getting the in-lab titration study, so the actual demonstration and desensitization is actually done when the equipment is delivered to the patient. So specific desensitization right now is not covered by any of the commercial payors. So for example, what you may have heard of is called the PAP NAP, is not covered by the commercial payors. Physicians could bring the patient in the sleep lab to work with a sleep technician. However, can everybody hear? However, they would have to bill. Okay, great. However, they would have to bill for an E&M code for an office visit code if an office visit was performed, but there's no separate CPT code that could be billed for desensitization in the physician's office like that. It's important to have follow-up after the patient receives the AutoPAP device, and this could be in the form of follow-up phone calls, checking remote download that could be followed up by the sleep technician, and also, of course, the office visits are important. Through Cigna Sleep, we have a special iComply program. That's our specific branded compliance program where we follow up with patients via phone call to see how they're doing with the equipment, and then provide some troubleshooting for patients who are starting on equipment as well. At the 90-day mark, there's required submission of compliance data to the health plan. If the patient is compliant, and most of the commercial payers use the Medicare definition, meaning 70% use for at least 4 or more hours in a 24-hour period. If they are compliant, then we're able to convert the AutoPAP rental to purchase. If the patient is compliant but is still symptomatic, it may be necessary to bring the patient in lab at that juncture for a PAP retitration. But the real question and the thing that we do when we do utilization review is to ask ourselves, is the PAP retitration going to be really necessary? Is the patient using the device and is still symptomatic, or is the patient using the device and has a residual elevated AHI with the machine? So if the patient is compliant but is still symptomatic, if the patient is compliant and has an elevated AHI, then we would say that the patient has failed the AutoPAP trial, and we would want to reconsider the patient for an in-lab PAP titration. At that point, it may be necessary to switch the patient to bi-level therapy, or maybe we're considering adaptive servoventilation, and we want to bring the patient in lab. If you're going to submit for a retitration, please be sure to submit the download information and the documentation that the patient has tried and failed AutoPAP. I can tell you a situation recently where I got a request for a retitration and the patient was on AutoPAP for 2 days. Well, 2 days is really not enough for me to say that the patient has failed the AutoPAP trial. So you really want to be sure to document that you're working with the patient is using the device but still has residual symptoms. Now, if the patient is just having mask issues or is having some anxiety related to the equipment, we would not approve an in-lab titration based solely on their own discomfort. So be sure to document that you think the patient would benefit from a bi-level trial and that the patient really has tried and failed the AutoPAP device. Documentation is really key. Other tricks that you can try for your patient with the AutoPAP, be sure to narrow the AutoPAP pressure. So patients that are set at a range from 5 centimeters of water up to 20 centimeters of water are going to have difficulty adjusting to those high pressures. When you do the download, you'll look at the 90th percentile and you'll be able to adjust the pressure accordingly. It may be beneficial to take an AutoPAP patient and set them at a fixed pressure, which would in effect be using the device as a CPAP. And of course, be sure to periodically review your download information to make sure that the patient is compliant and that the pressure setting or pressure settings are effective for the patient. If the patient has been on CPAP for quite some time and you're requesting a retitration, let's say the patient has lost a significant amount of weight, quite appropriate to reassess the patient. At that juncture, we would again consider getting an AutoPAP device for the patient. Perhaps it would be at home for a fixed period of time, let's say maybe 2 weeks, The download information would be obtained, and then the patient's CPAP machine would be adjusted accordingly. But just keep in mind that because the patient was diagnosed many years ago and requires a retitration, we may need to do the retitration using the AutoPAP device rather than bringing the patient in lab. You have to check the clinical guidelines to see what the indications are. So in summary, it's important to know and to understand what the clinical guidelines are for each health plan. They are basically the same, but there can definitely be differences. You want to be careful to document why you feel that the patient requires an in-lab PAP titration, and if the patient fails auto-PAP, really to be sure to document what steps have been taken to try to help the patient become accustomed to the device. If you do all those things and you feel strongly that the patient does need to have an in-PAP titration, you could request a peer-to-peer call or health plan appeal to dispute an adverse determination. Thank you.
Thank you so much, Dr. Aronsky, for sharing your payer expertise. Now a word from our sponsor, Fisher & Paykel. Fisher & Paykel Healthcare believes that gaining patient confidence is key to successful CPAP therapy, and patient confidence begins with a comfortable mask that fits. Developed from extensive patient-centered research, the tried and proven F&P Simplus provides optimal sealing due to the roll-fit design and the stability bar. The breathable fabric in the ErgoForm headgear allows for maximum head movement. The F&P Simplus is a mask that simply fits and performs. To learn more about F&P Simplus, visit fphcare.com/Simplus or contact your local Fisher & Paykel healthcare representative. I am now pleased to introduce Carl Stepnowski, PhD. Dr. Stepnowski is a trained clinical psychologist who specializes in behavioral sleep medicine. He is an associate professor of medicine in the Department of Medicine at the University of California, San Diego, research health scientist at the Veterans Affairs San Diego Healthcare System, and chief science officer at the American Sleep Apnea Association. He saw a need to apply a behavioral science approach to sleep apnea diagnosis and management, given that sleep apnea is a chronic disease that needs to be managed over time. He's been the principal investigator and co-investigator on multiple research grants with funding from the VA, AHRQ, NIH, and PCORI, among others. His primary focus has been on studying interventions to help patients adapt to using CPAP therapy using a variety of self-management and informational technological approaches. Welcome, Dr. Stepnowski. We're ready to learn from your expertise.
Great. Thank you so much for having me. What I'd like to do is give quick background on what I've done, how I got started, and then talk about some behavioral approaches to helping with CPAP adherence. And great talking. I caught the end. One thing I'd like to ask about are the health and behavior codes, because I actually mentioned CPAP desensitization later on, and wondering if that's a possibility. Anyway, I'm a licensed clinical psychologist who is doing behavioral sleep medicine before the term was probably even officially used in our field. What I did, where I really got interested was when I started following DME staff into sleep apnea patients' homes back in 1996 or 7, I think it was, and realized that there was so much that could be done in terms of education and support right from the very beginning. So I started a program of research related to improving CPAP adherence, and was really interested in the full range of issues related to adherence, from better understanding of rates of adherence, use patterns, why people use it, when they use it, partial use patterns, and then correlates and predictors of adherence, and then finally pulling all that together to try to study some interventions on how better to improve CPAP adherence. So in terms of correlates and predictors, when I'd first gotten started, we really were focused on more patient-related factors and sleep apnea and CPAP-related factors. And so started to look at behavioral and psychological factors, which we knew were modifiable. That was the problem with the other factors that were being examined, that age and education, you can't really change that, but you sure can change some of these other kinds of predictors. And then these could provide the basis for interventions to improve CPAP use. So I just give a list of some of the ones that we were interested in self-advocacy is the idea of, does someone have the belief that they can engage in the behavior? And I should say we really look at CPAP use as a behavior. There's a conscious decision to use it and then an action taken to use it. So it really falls into the behavioral sleep medicine model really nicely. Outcome expectations are the belief that engaging in the behavior, so using CPAP, actually has an outcome that someone wants. And then the decisional balance index is this relative weighting of pros and cons of using CPAP. And so early research found, to the extent that the pros outweighed the cons, people tended to be more adherent. So it's kind of a simple approach, but it was one that helped us structure interventions to help improve CPAP adherence. And the first one was a sleep apnea self-management program. And then once information technologies came into play, we started looking at the effect of feeding that data back to both providers and patients. What was nice is back in 2006 or 7 had one of the first studies showing that just feeding the data back to providers could have an improved effect on CPAP. And then fast forward to today, we're going with a national enterprise version within the VA healthcare system called Revamp, where we're doing that very thing. And now we're out to about 30 different VA medical systems. I just provide this slide to show where it all kind of started. And in 2001, the Institute of Medicine published a great report called Crossing the Quality Chasm. And what it really made the point of was that our healthcare system was geared toward treating acute illnesses, and that its approach was less than ideal for treating chronic illnesses. And 15 years later, I think some healthcare systems are really doing a wonderful job, and then some are still making the transition to improving how that care is organized and planned and delivered for those with chronic illnesses such as sleep apnea. And they had some foresight, if you look at the table to the right, that care should be patient-centered and efficient and effective and timely. So how does that come to be? The chronic care model is actually a really great model to help us better understand how certain aspects of care help produce better interactions between patients and providers. And so this model describes 6 essential elements. For sleep apnea and its treatment, policies tend to be higher level, but as you just heard from Amy's talk, the kinds of reimbursement policies clearly have an effect on the kind of care that can be provided and how it's provided. So policies are relevant. We tended to focus more on the other essential elements of the chronic care model. So, for example, clinical information systems are now a key foundational element for helping to improve use of therapy, because we're able to get objective measurement of not just the amount of use, but how well therapy is working or not working. Decision support helps to provide specific decisions that are made for more complicated aspects of providing care. For example, CPAP-induced central events, when to make changes to the APAP settings, when to change therapeutic mode, etc. And then delivery system design, or how are patient portals designed and implemented, what works and doesn't work. And I think this is an area of tremendous potential for sleep apnea patients. And then for the approach that I tend to take, the whole key is self-management support. How are we educating and supporting the patients to make decisions each and every day regarding their sleep apnea management? Share that one of the best talks I ever went to was at Kaiser Permanente back in the late 90s, and the chief medical officer there showed a picture of an iceberg and how the tip of the iceberg represented the professional medical care, and how the majority of the iceberg that you cannot see tended to represent self-care. And whether or not the percentages were right is not necessarily a point, but the point was that we only see patients in a professional capacity for a relatively small amount of their time, and that teaching and supporting self-management skills is really a good key task for providing good self-management care. You can probably tell I have half of this model hidden. So the key aspect is how all of those things come together to produce what the model calls productive interactions between patient and provider. I actually really like this phrase because throughout my clinical training and practice, it's easy to spot clinical encounter time that is not productive. So, for example, small talk or waiting in waiting rooms or or time to download a smart card, for example. But when productive interactions occur between patients and providers, there's actually some groundwork that needs to be done prior for it to happen. So on the practice team side, the terms that are used in this model are prepared and proactive. Prepared means that the team has objective information in front of them that's pre-read, analyzed, and that there's a plan in place before the patient even walks in the door. Proactive means that the team has taken those steps, oftentimes outside the encounter, to be sure the encounter can be as useful and valuable to the patient as it can be. And granted, I know I'm talking in an idealized way, and there's clinical realities that prevent this from happening in large part. So I present this model with knowing that it's kind of a pie in the sky sort of idealized way of practicing. On the patient side, the key terms are informed and activated. Information and education is necessary but not sufficient building blocks for behavioral change. Folks can clearly make behavioral changes without information and education, and it happens quite often. But for many patients, knowledge is power, and they'll often find out the information on their own. So one thing to think about is, where are patients getting that information from, and what's the quality of that information? Toward the end of the talk, I'll just talk a little bit about a clinical care process that we've actually had here at the VA San Diego for about 10 years. And there's some real advantages to it, but there's some real disadvantages too. So for example, that one-on-one time with a clinical care provider, physician level, nurse practitioner level, isn't necessarily built in anymore. And so where do those educational and opportunities come from? That's one big question as we move toward more remote monitoring and remote diagnosis. What we can do is take a look at the CPAP adoption process in terms of several phases. And if we look here, broke it down into start, establishment, and maintenance. And really start, even though I say up to a month, it could be as short as a couple of days on the fast side, and up to a month for some of the longer folks, and sometimes beyond. CPAP establishment usually happens after start is completed and goes on for several months. And then maintenance is after a good pattern of use is well established. The goals are different by each phase. So for example, a CPAP start, it's really getting used to the nuts and bolts of CPAP and an understanding of sleep apnea. And in the establishment phase, the goal is really what I like to call giving CPAP a fair trial. And when we were doing some of the early work on designing intensive interventions, what we kind of hit on that term because we just wanted folks to use it for several nights at the right pressure with minimal side effects and minimal problems so that they could really see what the effect of CPAP was on their sleep. Once we got them to a fair trial, then they could make a really good determination of whether CPAP was for them. Before that, it never seemed like they had all the information they needed to make a good judgment. I should also add here one of the early studies by Hoy and colleagues, and we can pass it out. I looked at it. It was called an intensive intervention, one of the first CPAP adherence interventions that was published. And when you looked at the number of hours of clinical care provider team contact, it was 40 plus hours for each individual in the study. At the time, 10 years ago, that was not feasible. And when I was submitting some of my early grants, even suggesting 4 to 5 hours of contact was getting criticized. So we have some data that shows that we can get pretty good adherence by even as little as 1 to 2 hours of contact, which is I don't think we can go much below that. CPAP maintenance is then the goal is maintaining regular use over time. And oftentimes we neglect these folks, but really understanding some of their issues to really maintain CPAP use then for years is important. And I'll show some CPAP adherence data over 365 nights toward the end of the talk. What are some key considerations by phase? Let's see. Review of what is known and not known about sleep apnea. And I put this out there because I think what we're seeing more and more of is that lack of opportunity for a good understanding or sit down with the physician about what is sleep apnea, what's my sleep apnea like, what's my interpretation of the sleep study, what's my positional AHI, what's my REM-related AHI. I think we're missing a lot of opportunities to give good educational information right at the start. And then introduction to CPAP and its mechanism of action. I can't tell you how many patients I still talk to who don't have a good understanding about what is it about CPAP that really helps produce the effect. And there's a distinction between the pressure and the features of PAP. And so, for example, that's why I was late to this call, working on a national study with the COPD Foundation where we come up with an interventional program all online, and this is one of the key things that we talk about are a really in-depth review of features and how it differs from the pressure. And nowadays that everyone has so much access to the data through the apps, getting better understanding or education of the patients about what does CPAP use mean and what do the efficacy metrics mean. Efficacy metrics being leak and AHI primarily. We've often seen that the number one complaint is the mask in this early stage, but what we actually find is that it's the breathing against the pressure. There's no doubt the mask fit has to be right and has to be a good fit for the patient. But we also have found that it's that breathing against the pressure that can be foreign and difficult for many folks. So having them practice in a variety of ways is one of the more important things. And this has to be customized based on the patient themselves. So whether it's just recommending that they use it while at home and relaxed, whether it's doing it in clinic or in DME against higher pressures, that's our local pulmonary sleep doc, that's one of his go-to methods, is to have them use it at a relatively higher pressure than they're used to, and then lower pressures feel like it's much easier. It also helps to set the mask better. And then finally, the I can't breathe. So the focus on exhalation because of the paradoxical effect of experiencing difficulty breathing while having access to a lot of air. And so that's one of the things we've addressed in our research studies. And then that's why I brought up the systematic desensitization, because oftentimes it's relatively rare for having a truly diagnosable claustrophobic patient, but a lot of people do have difficulty wearing the mask and feeling comfortable with it. So basically doing systematic desensitization light procedures. During the establishment phase, there's a different set of priorities. Now we've overcome the beginning parts and some of the basic questions and some of the basic mask fitting stuff. And now we're more into troubleshooting other kinds of problems. And so I've always taken the approach of patient-centered collaborative care, where we're really working side by side with the patient and helping them work through the problems so that they have the information and knowledge to really kind of be more directive and have a good understanding of how to fix the problems that they encounter. On the opposite side, it's not just reducing the problems, but it's maximizing the benefits. And for severe sleep apnea patients who experience that wonderful, change of life event, that's easy. But for the folks with mild to moderate or even severe with low-level symptoms, being on the lookout for the benefits experienced is really important. So making sure that all the obvious ones are linked back to sleep apnea is important, but also the ones that are not so obvious. So for example, reduced bathroom visits at night, improvements in irritability. There's a whole host of these sorts of things. Some of our veterans, when they report that they reduce their bathroom visits from 4 or 5 to 1 or 2, they're ecstatic. And we've also had folks who, it might take a month to really notice or to get the feedback from the family that they're not as irritable and unhappy anymore. You can link that back to better sleep. And these are the motivations that help people understand and makes it worthwhile to use CPAP on a nightly basis. So the dynamic going on during this period is that relative weighting of benefits and problems. And the key question that the patients are always thinking about is this worth it to me? And then the maintenance tends to be a period of rewarding interactions, begin to focus on some fine-tuning. So for example, hitting on exactly which mask type or which combination of masks. We have a lot of people who like combination of masks depending on where they are or how they're feeling. Pressure levels should be ideally dialed in by now, and if not, a physician should be consulted, especially with APAP. Some physicians take an approach of keeping it 4 to 20. Others really like to start to look at the data and start adjusting the minimum and maximum values, for example. We should also start to see variability in use levels be leveling off. Although the data I'll show you on the next two slides counter that a little bit. But what I mean by that is oftentimes in the beginning people take some nights off because of skin problems or whatever. And now we really should start to see those problems leveling off. And the patient should have a good understanding of obstructive versus central events, especially if they're keeping an eye on their AHI and they're wondering why it's maybe higher than expected. And during this period, we really should be seeing the patient starting to lead their care now and working together with the DMEs to make sure that they're getting the product replacements when they need it, and troubleshooting most problems is important. And then there's always the smaller issues, right, like the traveling or camping, dealing with use of batteries, loss of home power, etc. So really helping, when you get people talking about that, you know that these are now regular users. Going to the adherence graphs, I had the opportunity to measure 1 year of CPAP adherence data in 240 sleep apnea patients as part of a larger clinical trial and plotted the nightly use amounts over that 1 year time period. And what happened was the statistician at the time, phenomenal statistician, he said, you're using the metrics to summarize some really rich data. He's like, I really need you to take a look at the scatter plots because, you know, we can summarize it with several metrics, but you're just not getting a good feel for it. So he created these and we went through them together. And the number one word that came to mind as I went through this was variability. Even in I'll give you the bottom line, was even in the best users, there was still variability and there was still waxing and waning over time. I'm not going to share all of them with you, but I'll share 2 slides with you. This was probably the best person. I thought one of the most instructive because this is someone who had a tough start. And if you look closely, the average probably would have been below 4 hours, probably closer to 2.5 hours. This person may not have met criteria and kept it with the current reimbursement policy. But this is someone who stuck with it. So the dots represent each individual night of use. The over 365 nights. The blue line represents the average, moving average line. And the arrows represent when we had a clinical encounter with the patient. And we really tried to keep these encounters. They could have been in person or by telephone. We didn't keep track of that on these arrows. There was just some contact. And you can see we'd like to attribute those 3 contacts to helping that person not stop and actually increase use as they went from month 2 to 3 to the 90-day point. And then there was something going on where there was two interactions, and we see a nice ramp up. And then this is someone who really started to continue to use it pretty well over time. And it's really a tale of 2 half-year periods. If you look at the first half-year period, we see wide variability in use, all the way from not using it on multiple nights, consecutive nights, but there was some really good time points too, where using it for 8 or above 8 hours a night. And then in the second half, you can see the number of dots at the 0 level significantly went down, and the variability also slightly decreased. So those lack of use nights really went up, while the number of 6 to 8 hour went up as well, which brought the average up. So this is someone who really was a steady increaser over a 1 year time period. I can tell you that this was less than a handful of the 240 people. The next person is a little bit more representative of the waxing and the waning. So we'd like to think that those 3 encounters made a big difference for the person within the first 30 days. And they experienced some good success with it. And then there was some changes that had happened. So you see the decrease And even that clinical encounter at the 120-day mark didn't necessarily matter. That person was on a downward slope, had lots of times where they didn't use it over at the 150-day mark, and then made a choice to start to use it more again. But this is a waxing and a waning that's pretty consistent. If you can imagine the use patterns, every single thing you could imagine we saw in these 240 people, from folks who started off like gangbusters and literally stopped within 2 weeks, never to pick it up again, all the way to this kind of variable use. So I just point this out because it's really important. We like to summarize the metrics for each person over time, and sometimes we'll see 7 nights or we'll see 30 nights. But to really see more nights and what the trends are, whether they're an upward trend or downward trend, and for that individual understanding what the factors are that might be associated with a downward trend or upward trend, is important. So I just wanted to share this slide. I'm not sure how visible it is, but this represents the clinical care process for almost I can't say fully remote, but for a program that uses, that's high volume, pretty much sends 95% of all sleep study consults to have a home sleep apnea test. If the test is positive, CPAP is ordered. So I'll go to the next slide because the top quarter just represents the consultation process. This represents the bottom third, which is more relevant. Once they have the sleep study, it's scored. If there's a positive diagnosis, CPAP's ordered, and they're simply called for a CPAP setup. And at the CPAP setup, it's often done in a group situation, and then there's typically 2 follow-up phone calls that are scheduled. And I just point this out. What you see in the other 2 columns are interventional groups for our research studies. The middle one's usual care, and the one on the right is the interventional group. And the only points I wanted to make here was that in this model, the opportunity for good education is limited. Even though improvements were made to the group sleep study education that had happened, it happens middle of the day, 5 to 10 folks come. They're told that they're at risk for sleep apnea to do home sleep apnea testing, and they're told quite a bit about sleep apnea and CPAP therapy. The problem is they're not diagnosed yet, so they don't necessarily hear it to the same degree that they would had they had the same group education session post-diagnosis, which is a limitation. So I think when we talk about doing more of a remote process like this, there are some challenges, especially if we were trying to provide good education and good support. One of the biggest things that's missing is that time for shared decision-making between patient and provider on, just like I started off the talk, tell me more about my sleep apnea, what's the full range of options, which is the best option for me in getting that initial buy-in. And I think that could really help with then laying the groundwork for a good APAP trial post. So conclusions: identify the current phase that your patient's in and tailor activities to that phase. Think about these and other key considerations and tips that work for you and your program. Think about adherence data as behavioral data. A lot of what you need to know about how that patient's doing on PAP is in that data. And it's just a matter of figuring out what are the factors that are helping to increase or decrease the use levels. Behavior change is a multifaceted process, and know the role in helping to facilitate that change in each encounter with the patient and aim to make each interaction as productive as possible. We're always laying the groundwork for future behavioral change in those moments when we're with our patients. And even small positive reinforcements during phone calls, for example, can go a long way. So don't forget, it's not just helping with problems, but it's also providing that positive feedback to encourage continued use. And behavioral change is a long-term process. There may be patients who make a conscious decision to use a different therapy. As long as CPAP's given a good trial, we've found that they will often come back to it knowing that it has a very good effect. I'll stop there.
Thank you so much, Dr. Sepnowski, for an excellent presentation with such important information. We're about to begin the audience Q&A. If you're enjoying today's webinar, subscribe to email notifications about future events at www.sleepreviewmag.com/subscribe. And now let's take our first audience question. And Dr. Ockley, this came in during your presentation. What happens when you add humidification or choice of mask? Does that change the adherence rates for CPAP versus APAP?
Yeah, so humidification has been around really, is considered standard of care nowadays. It's been around for a while. Initially, the humidifiers were primarily Passover, cooler, but it's probably been almost 20 years that really they developed heated humidification. Now that the technology is quite advanced and the humidification can be fairly precisely controlled. But it's been shown and known for a while that heated humidification clearly improves PAP compliance. Comparing fixed to auto, I'd assume, the studies that were done were all with fixed. I'd assume that can be translated to auto CPAP as well, but I'm not aware of any head-to-head studies. But I think almost 100% of our patients certainly get set up with heated humidification when they're getting set up with CPAP therapy, whether it's fixed or auto. Similarly, the interface obviously is clearly important. The patient has to be comfortable, has to fit well. You don't want to have leaking problems. If it's uncomfortable, if it's leaking a lot, the patient will have poor adherence to therapy, and that'll be an ongoing problem or may cause them just to fail completely. So it's definitely very important. But in terms of data comparing different interfaces and the different modalities of PAP, I'm not aware of anything specific in that area. But it's certainly just based on anecdotal experience and clinical experience, it makes sense.
Thank you. Dr. Aronsky, this question came in for you. This person says they've had patients that fit the medical necessity requirements, but it was still an adverse determination. It appears it's always going to peer-to-peer, and the providers do not have a lot of time to do these regularly. It appears some insurance may know providers do not have this time and always deny in-lab titrations across the board. Any suggestions?
Yeah, I would say, first of all, thank you for the question. And we always want to do the right thing for the patient. And all the clinical guidelines are based on best practices and clinical studies. I would suggest that if all your requests are getting rejected, there's something that you're not understanding in the clinical guidelines. And I would suggest during the peer-to-peer call that the reviewer spend time, the physician reviewer, spend time going over some of those questions with you to make sure that you understand why something is getting rejected. I always spend time during the peer-to-peer calls to educate the healthcare professional who's making the request as to why this was rejected. So my suspicion is that there's some type of disconnect in terms of why this is getting rejected. Once you're familiar with that, once you have a couple peer-to-peer calls, then you'll understand why it's not going through. It just may simply be that the patient doesn't meet the clinical guidelines and that you do have to go to AutoPAP. It's very interesting to note that the actual number of cases, out of the actual number of cases that come into us, fewer than 10% are actually denied. So the vast majority of the requests that come to us are actually approved. So as long as you have the right documentation and the clinical guidelines are met, your requests are going to be approved. But I would use the peer-to-peer call as an educational experience to understand why this is getting approved, why this is getting denied.
That's great advice. Thank you. Dr. Sepnowski, this came in during your talk. What is the benefit of a disease management type of program that uses the trans-theoretical model to assist the patient from making CPAP therapy a part of their life?
Sure. I think the most important thing is then the specific education and support can be more tailored to the specific stage that someone might be in. And I think that's probably the most important aspect of using the stage of change approach. As an example, the very first stage of it is pre-contemplation, where someone's not even considering behavioral change. So for someone like that, we wouldn't say, okay, time to start doing something. We would say, well, let's talk about the pros and cons, for example, of why you're not thinking about doing it. So that's why taking that sort of approach can be a helpful framework.
Great, thank you. And Dr. Sipnowski, do you have any insights on this next question about do many DME companies keep their patients on the AutoPAP after the titration? Most in this person's area switch to fixed CPAP after that.
Oh, there's probably some regional differences, and I mean, I know out here in San Diego, oftentimes the folks who are prescribed PAP keep PAP and stay on AutoPAP. So it's probably just some regional or practice difference for that.
And the next. Oh, yes. If anyone else wants to weigh in on their experience with if DME switches to CPAP after AutoPAP, feel free to weigh in before we move to the next question.
I would just say, yeah, I agree. It's regional and also very dependent upon insurance. We have some insurers that require AutoPAP, that there be an AutoPAP titration, the patients stay on it. We have some that do the opposite and require in-lab titration and fixed pressure. So it's something I think that's in flux. I think we are setting more people up on AutoPAP devices than we had previously, but a lot depends upon just those factors.
Great, thanks for weighing in. And Dr. Ockley, perhaps you have an answer for this next question. This person says, often when we switch a patient to a set pressure, they begin to have centrals. Any feedback as to why?
I guess it needs to be, I'm not sure the context of that. If it's during a titration study, that's a recognized phenomenon that can happen in a small percentage of patients. That's the treatment emergent central sleep apnea events. That what we know from the literature is that the majority of those will resolve over time if the patient is left on the CPAP setting. That by and large eliminates the obstructive events before they get to the central events. Most of those will resolve. I'm not sure I've seen a lot in terms of patients who are on auto devices getting switched to fixed pressure based off an auto download developing centrals. That could be, when we see centrals on CPAP, there's always a number of things you want to think about. So, one of them is just, is there significant leaking going on? Is the patient having a lot of arousals leading to transitional central apneas? Is it more of a problem with treatment emergent phenomenon? And you also have to put in the context what their underlying clinical comorbid conditions are if they do have a impaired heart function or neurologic disease. So those are things I guess I would sort of think of, and again, have to put in the clinical context of what exactly the situation is.
Great, thank you. Dr. Aronsky, this question came in for you. This person says that it seems inappropriate to have a non-sleep provider review. Can you share any insight as to what the justification is this on the payer side? Is it a fiscal decision?
Yeah, that's a good question also. So everything that we do in utilization management is based upon regulations and compliance. And from a regulatory standpoint, a peer-to-peer call just has to be a clinician to a clinician. There's nothing specific that says that it has to be in the same specialty. Now, as the process moves along and as we go on to second and third level appeals, generally those providers are going to be in the same specialty. But a peer-to-peer call may not be in the same specialty. It may just be a matter of availability. If there aren't a lot of sleep physicians available, it may just be that they have to, use whoever's available. But from a regulatory standpoint, peer-to-peer call means clinician to clinician.
Great, thank you for that explanation. Dr. Stepnowski, this one is for you. Where do you see, if any, the future increased need in the healthcare practice for physicians to hire senior sleep techs, certified clinical sleep educators, to assist them in tracking and managing their patients' care long term?
Sure. What a great question. I think there could be a great role for sleep techs or certified sleep health educators. I think that might be one of the gaps that's needed in the area. I think what we need to do as a field is take a closer look and kind of survey practice patterns and really say, is this truly a gap, and if so, what's the best way to fill that gap? But that would be a natural, especially as fewer PSG techs are working at night and moving toward the day.
Thanks for sharing that. And then we'll do one final question for Dr. Aronsky. Are the health and behavior codes still in use, and if so, are they used very much for some behavioral approaches to OSA that could be a factor? So the health and behavioral codes.
I'm not exactly sure what that's referring to. I think we're talking about for PAP desensitization. There are. I'm sorry.
Yeah, so Amy, that was my question, because the health and behavior codes is if there's a diagnosed medical condition, then some of those behavioral approaches might be covered. So I was just wondering if they're being utilized at all or not much.
Yeah, I think in general that they're being underutilized, and certainly that's one option, particularly, for example, in group therapy and things like that, and those models are certainly in use in some of the larger institutions. It's the Kaiser Permanente model as well, where Kaiser is the health plan as well as the insurer. So that's another way that can be instituted. But right now, paying for getting a desensitization covered right now is really not an option. Again, a lot of people cite the PAP NAP, but that's not covered by commercial payors.
Well, in order to finish on time today, I want to conclude by saying thank you to our three presenters, our sponsor, and to our audience members. Today's webinar is being recorded, so you may rewatch for free anytime using the same link you used to log on today. Feel free to share the link with colleagues who may have missed today's live event. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions. And visit us at www.sleepreviewmag.com. Thank you for participating in the Sleep Review webinar.